Hello, everyone. Dr. Annalyn Schooley, president of the Florida Family Therapy Alliance. It is February 2026, and our speaker this evening is Dr. Larry Barlow, a friend from, I don't know, 30 years or more, Larry. It's been
Oh
a very,
yeah,
very long time
definitely.
since my student days. So it's very lovely to have you here tonight. He is currently a full-time faculty at the Capella University in the Marriage and Family Therapy program. Long time private practice owner, and more exploits than I can even tell you about. But when we send you the information, I'm sure his bio will be there. Welcome everyone to Working with Older Adults. And Larry, I am thrilled to turn it over to you.
Thank you, Emily. So I wanted to start tonight doing something a little different. I know this may take a minute, but I think it's worth it. Um, I was a good older senior today. I had two doctor appointments. If you have at least two a day, you know that's something you get used to, right? So I went to the retinol specialist, the yearly checkup, because I have dry AMD, macular degeneration. And he tells me at some age, all of us, if we live long enough, will have at least dry AMD. We don't want to have wet AMD. My mom had that. And so, anyway, so I did that one. And I went back to see my specialist, dental specialist, the periodontist, who put in two implants about 2 weeks ago. So, so it's, and he said they look great. The implants doesn't mean I have teeth, so I've got to wait and get all that set up. But eventually, I'll be able to chew again. So I look forward to that. Um, so what I wanted to check in with you about is, and I'll go last at this, and I'll just call names out. So if you're in practice, I'm going to ask you about how many senior clients, so over the age of 60, how many senior clients virtually do you work with? And what's your oldest client? How old's your oldest client? So, Tommy, I'm going to start with you if you don't mind.
Hi. I have about five older clients, and they range between 60 and 80. My oldest one is
Great.
probably 80. Mhm.
Yeah, great. Lynn, how about you?
I don't think I have any currently right now. I did just meet with a one time, like a couple for one time, and they were in their 70s just
Mhm.
today, but they were very upfront that this was a today only kind of a thing. So,
Yeah, 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 that happens.
Mhm.
That happens. And Annalyn, how about you?
I just have one that's over 60. But then I
Mhm.
also have a very, very tiny practice. Unless you want to count
Yeah,
my mother, who's 89.
yeah, that should count. And it just says owner, so I apologize. I don't know.
I don't know
That's
how to
Linda.
change it. I would change it, but I don't know how.
The-
I am not a tech queen.
Yeah,
Um, I have three, and oddly enough, they're like Tommy's. They're between 6 and 80,
okay,
60
great,
and 80.
right. Robin,
Think I have about 10, some
wow.
clients. And so the oldest I think right now is pushing 80.
Okay, okay, thank you. You have a big practice of
Well,
seniors.
since I started taking Medicare,
Yeah, yeah, yeah.
That makes sense.
Meredith,
I have about five,
cool.
and they're running about 75, 77.
Okay, so getting on up there. Kristen,
So currently, I have one couple in which the husband is in his 60s.
okay, thank you. Karen,
It looks like I have three or four that are in their 60s, but I've had much older.
yeah, yeah. They do die at some age, unfortunately. That's one of the things of working with seniors is they do die. Thomas,
Yeah,
We have
I'm
two
sorry. Oh,
Thomases.
I'm
So
sorry,
Thomas
Thomas
Robbins.
Robbins.
Yes.
Okay. Yeah, I work with the military families right now, and so I have no one over 50.
Okay. Okay.
But I will say one of my most memorable back when I worked for the Archdiocese of Louisville, one of
Yeah.
my most favorite was a couple in their 70s, excuse me, in
Right.
their 70s who came into sex therapy.
Oh yeah, I've had that.
So that was
Yeah.
fun.
Some of the functioning is a little hard, not hard at that
As,
age, right?
as it were. As
Oh,
it were.
Larry.
Yes.
As
As it
were.
were.
Yeah. Tom?
I have over a dozen.
Oh wow.
My
Great.
eldest is 85.
Oh, super,
He's a
super.
Navy veteran.
Oh, wonderful, wonderful. Yeah. Annette, how about you?
I don't know. I mean, I'm going to be 60 this year, so I've been noticing over the last 5 years that all my clients are aging. I've
Yeah,
definitely had some 80s and 90s, but I would say
yeah.
in general, my couples are over 55 now. And
Okay.
that seems to be who I've noticed that, who's attracted to you is
Right,
within,
right.
10 to 20 years of your age.
Yeah, 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 yeah. And Beth? Beth, there she is.
So I haven't practiced for a little while since graduating, but when I had my student internship, I had three clients over 60. One was about 70, one was
Mm-hmm.
in her early 70s, and the other one was 82, I want to say.
Right, right. Thank you. And Norman?
Uh, that's a hard question because I guess I'm now up there to almost senior age. I'm going to be 57, so I'm getting there. So
Uh-huh. Uh-huh.
currently none right now, but in March I left a medical practice that had a behavioral health component here in Wilton Manors, and most of my clients were of senior age.
Okay. Yeah, yeah. A lot of retirees. Ariel.
Currently none, because I'm kind of like Anna Lynn. I've let my practice get pretty small.
Yeah.
And I just have a couple of people, and they probably are closer to my age, but I have a couple female clients that are in their early to mid 50s, kind of getting there right now.
Super. Well, let me share my screen and I'll share a little bit about my practice. Okay. Let me get it set up for the slideshow. Hold on now. Some of them work. There we go. Okay. Can y'all see that okay?
Yes, sir.
Okay. So, yeah, I'm not going to say so much about all this. So I'm going to start with this, and then I'll tell you about my caseload. So if you look on the kind of the first row to the right, the young man there, he was very young at that time, is my dad. And my mom and dad have both been deceased about 10 years, about a decade. And he was in World War II, and he flew on the B-24 Liberator bomber. And his bomber was named several things. And of course, it was different bombers because they got shot up and stuff like that, of course. And the first one was Just One More Time. That one was not one he flew a lot. The one he mostly flew was called the Red Ass, and it's actually in the museum, the Air Museum in Tucson, Arizona. And my wife and I, and Lynn, you remember when we went to Phoenix? I don't know if you went to Phoenix. I think you did. We went out there to teach residency a few years ago, and my wife and I went out a little early, rented a car, and went over to Tucson, a couple hours away east of there to see the exhibition. They had the exhibit on his plane because his plane was the lead bomber on D-Day. And he there was very young, and he was the youngest and the smallest. So they put him in the back of the plane. The B-24 Liberators had this rear gun, tail gun, and that's what he did most of the time. was he was back there with no protection sticking out from the back of the plane. Never got shot down. One time, he counted when they, or somebody counted when they got back from the mission, and they had 78 bullet holes in the fuselage. But as long as it didn't kill the pilot or co-pilot or blow the engine up, they just kept flying, you know. So he was very fortunate. Now the third name there is because they were the lead bomber on D-Day. So the Army Air Force did not want in the news that the red ass with its donkeys with the ass stuck up in the back, painted all red. They did not want that in the news. So he was in Bungay, England, where they were stationed, and they named it the Bungay Buckaroos, and it had a bucking horse, and so that's the name they changed. So if you go to Tucson, then they have a huge air museum. You would see on one side it says the Red Ass, on one it says the Bungay Buckaroos. So this is also a picture. Let me move the pictures out of the way over here so that it won't be blocked. So this is in 2001. This was my mom's 80th birthday celebration. And all the families there, you see grandchildren, not a lot, but you see some grandchildren. And you see my brothers. There were 5 of us, no sisters, just 5 boys, and some of the spouses and stuff. And you see my dad and mom down at the bottom there. So my mom lived to be 88. So that gives you a time. And my dad, we didn't think my dad was going to survive her illness. And they could not believe that she died first. That was a total shock. In fact, my dad didn't let us read the will until after he died. And the will said that everything would be left to my mother, and then it would come to us. So actually, for 2 years, everything belonged to us. We just didn't know that, you know. So the house that I was 2 when they moved into it, and they were still living there when my mom died, and then my dad died 2 years later. And he died. The 2 things that people have to really watch for as we age are what? Falling and infections. And unfortunately, he went in the hospital for surgery. It was kind of an iffy thing. He decided he wanted to do it because they told him it would kill him if he didn't. It just would be that he might have lived longer than 2 years had he not done that. But he had an aneurysm in his abdomen, and he went in for surgery. Almost died, didn't. He survived the surgery. But then about 3 months after the surgery, it exploded because of an infection. He got 5 infections while he was in the hospital, which is, you know, that's why you don't want to go in the hospital. That's not a good place for us to go. So let me tell you a little bit about my practice, and then I'll tell you about this thing. I'll move this over here out of the way so it won't bother you. So my practice is very small. Like, I think 2 weeks ago, I had 4 or 5 clients. This week, I think I've got about 7. And I've limited it pretty much now to 2 types of clients. I love working with couples of all ages. I had one today, a new couple, and they were 22 and 20 years of age. They're engaged and separated. So that's not good, but we'll see what happens. And then seniors. Yesterday, I had a brand new senior came in. He was 74 years old, and he had moved from South Florida, and they told him he had to come to therapy because he was depressed. He wasn't really depressed. He was just pissed off. So he's an attorney. He loved living down south, and they had a home in the mountain that he called his dream home. And they were loving going in retirement back and forth. going in the summer up to the mountain house, and then in the winter back, in the winter back to Palm Beach County. And they changed that and sold their stuff and moved to Tallahassee. And he's just not happy. He's not happy, and they're considering moving back to South Florida, where he has friends and activities and things like that. So another story about one of the books, actually, this was recommended to me by my oldest client. So my oldest client is now 101 years old. And I just saw him Monday a week ago. The reason I saw him then is because his son from the Northwest came down, his daughter, they built an apartment onto his house about 20 years ago. And she moved into the apartment, and she's not a nurse. She's very clear. I am not a nurse. If you need a nurse, we'll hire a nurse, not an aide, but I will be here and I will enjoy playing a card game with you at night, and maybe eating together some nights, and I'll take care of managing your finances and all that stuff. And his son, who's in the health care world, and he's in his 70s, I think he's 72. He was there to visit, and so we met to just kind of do an update. His wife, who died, I think in May, was 98 years old, and she was a very strong reader. Robin, she would have loved you to talk about books and stuff. And she had gone into assisted living, and that's the reason I saw them over many years. But at some years it might be 2 visits. Some years it might be 6 visits. And so they told me about this book. This is a New York Times writer, or she used to be with the New York Times, Jane Gross. Her mother lived down in Palm Beach County, I believe. And her book is The Bittersweet Season, Caring for Ourselves and Our Parents. It's a wonderful book, I think. It describes the meaning of the term. It was difficult all the way, but our relationship changed dramatically in the last 2 years. I came to love her, she came to love me, and my guess is we both did all along in our own prickly way, but it was all out there at the end. And it's just a wonderful book about aging and about family relationships. They did not have a close relationship. She had a brother who was less involved at the end than she was. And she was in New York working for the New York Times. Her mother was in Palm Beach. There came a time when her mom could no longer be in assisted living. And so she had to move her to New York City where she could be with her. Her mom was a prickly person. I didn't know her, of course, but she was a prickly faced person if you read the book. Her mom at one point lost the ability to speak, so they gave her a machine with buttons on it, and she would push the button. I need to potty. I need to drink of water. And one of the buttons was, "Fuck you, get out of this room." So that's the one she did with the priest one day, from what they share in the book. So, so we may all need a machine like that someday. Any questions, comments? Just interrupt me. Anything anybody wants to share. So part of this is a PowerPoint that I did last spring. LMFT has now created a certificate for working with older seniors. And this is one of the 4 modules if you want to become certified in it. They're good. They're all good, I think, for what they are. They all were on different emphasis and stuff, but I think all the people who wrote them were well qualified. And part of what we tried to do is make it a strength-based emphasis, being MFT. And this fits, I think, with Jane Gross, because her life was better once she got close to her mom, and they worked out their relationship in the very end, the last years of their life. So there's some myths about aging, and I wanted to cover this. This comes from the Harvard Pilgrim Healthcare. We have a lot of myths about the body and everything. So do you know what the aging criteria is now? It's changed over the years. So now 55 to 65 is not old, it's young old. So if you're 55 to 65 or your client is, you're in the young old category. If you're in the 65 to 75, you're in the old category. And if you're older than 75, you're in the old category. One of the myths is that aging means the end of cognitive development. When you get older, you will invariably experience dementia or another memory disorder. So there's something called normal aging memory issues. And I've had clients who wanted to get kind of a belt line of, well, where am I with memory at whatever age? And you can do that. Most hospitals that deal with aging have a clinic for seniors and memory issues. And you can go in, and if they tell you, well, you're really just experiencing the normal memory loss, then that's a good thing. And most people, that's what we experience. I'll show you some statistics later about loss of memory. So what are the first things that we lose? This is a question for everybody. In terms of memory, what are the first things that normally we lose as we age and get into our 70s?
You mean like keys?
Short-term memory?
It's nouns.
Oh, nouns.
So, yeah. So how many times have you sat and said, oh, I know that song, and the person who's singing it is, and it's just not there. It's like you can't pick the suitcase luggage up and get it, when 10 years ago, you could easily do that. And that's what we mean as an example of normal aging memory loss, is it just takes us longer. And it may be, for me, sometimes it's 20 minutes later and I'll think, oh, Jane Gross wrote that book, but in the moment it escapes me and I just can't quite grasp it. That doesn't happen all the time. But the other thing is with names. Have you seen people with names? And so that's part of the memory loss. That's normal. So, but a myth that we all are going to have that is not, that's not normal. Another myth is that depression is normal and to be expected in older adults. That's certainly not true. It certainly can be there, but it's not normal that most of us are going to be depressed. It is the most common mental health issue for older adults. Anxiety and depression are both the two most common ones, but it's not normal that we, all of us will get depressed. My client who died in May, I think it was, 98 years old. So she went into assisted living because she had been an alcoholic and never got real treatment for alcoholism. She grew up in California, and so every night she had a cocktail and she had wine with dinner. But wine with dinner was like this size. It was a goblet size. So I just drank one drink of wine a night, but you finish a bottle very quickly. And so she was having trouble with falling. which I say, as I say, that's one of the common things that we have to deal with. And it just wasn't safe for her to be home anymore. Her husband being older than her, at that time, he would have been about 98 himself when she first went in. She was about 3 years younger. And it was good. It was a good, it was literally 2 blocks from their home. So it was easy for family to just go right there and see about her. And when mom couldn't get the TV to work or something else, and she couldn't find somebody there in the assisted living to help, then somebody could run down there and do that. But it was a very nice room she had. It was a studio apartment. So it had a nice bathroom, big shower. It had her bed. It had a sofa. It had some of her art, some of her books. It had a little exercise machine and a little kitchenette. And before very long after she was there, I would go in to visit her about every 2 weeks for a while. And it was dark. She would shut the blinds invariably, and I would go in and it's dark. She would turn the light on, but she would say, "Welcome to my tomb." And there was truth in that. She died there in the room with hospice care. It was very good hospice care, but she did have depression and anxiety. But it's not true that everybody's going to have that. Senior citizens should skip strenuous exercising to avoid injury. Certainly, there are issues that can come up, that we can fall or something more. But, part of being a healthy senior is doing what? Exercising, right? Whatever it's safe for you to do. And physical therapy, a lot of seniors I know do go at times to PT, and it really helps with shoulders, with balance, with all sorts of things. You don't need as much sleep as you age. What do you think about that? No, that's not true. We still need 7 or 8 hours or more. The problem is what? It's not that we don't need it. What's the problem with sleep?
Interrupted, waking up in the middle of the night.
Because
to go to bed.
Bladder.
You got bladder issues. You need to get up 2 or 3 or 4 times. Or you have pain. That's the other thing. We get interrupted because we wake up and our shoulder's hurting, our hip is hurting, our arms are hurting, something like that. So it is a challenge. But we do need to maintain those foundational things like exercise and getting good sleep and a good appetite. So strength-based emphasis on MFT, what does that mean? It means that successful aging or active aging, emphasized aging can be a period of continuous health. And this was from the American Journal of Family Therapy, 2024, if you want to read that article. Strength-based therapy builds resiliency and helps older adults and families find new coping strategies and effective ways to address issues related to aging and life changing. So I'll tell you a story again about the family. So as we dealt with the issue about the alcohol use, I did a lot of research and came up with, part of what changes as we age, if we still drink, is what? Are we going to metabolize alcohol the way we did when we were 20 years old? No, we're not. We just don't metabolize it as well. And so that's part of the reason that it has a bigger effect. So my client didn't accept that. There was a lot of strength-based stubbornness, which was good. She was a big advocate for herself. I'm 95 years old. I ought to be able to do what I want to do. And I get that. So with the family, because we included the family in making decisions, with the family, I threw out and said, well, if we go to a psychiatrist and they look at everything and they give you some direction, would you accept that? And her husband liked that idea, which meant that she was going to like that idea. In their family, that was kind of the system. And so we went to a psychiatrist, and the psychiatrist was wonderful, young lady. And she was great. She listened, she was empathetic, she was knowledgeable. And so she said to her, rather than say, no, you can't drink, because that would not have gone well, right? She said, you know those bottles you get on an airplane, little tiny bottles? And she said, yeah, of course. You can drink 3 of those a week. 3 of those a week, and that's okay. You choose when you want to drink them. You don't drink them all the same night, but you drink them three times a week. 1 bottle 3 times a week. So that'll, that would be 3 bottles. And what do you think happened?
Well, hopefully she drank less than 3, but at least she only drank 3 probably.
She drank 3 for a little while, and it was kind of like, screw this. I don't like it. It didn't meet her need. It wasn't the same ritual, because she had grown up of a ritual. That's what her family did. She grew up with that. It was a ritual with her and her husband. They had the cocktail late afternoon after work, and then they had the wine with dinner. And that was great. It was a great ritual. It just wasn't healthy at that point. So that's what, we have to do coping strategies. We have to do resiliency. Anybody want to give some examples of how that shows up in your practice?
Well, that's similar in my practice. I just recently was talking about buying alcohol-free wine for someone's mom and
Yeah, she
discussing
tried
how,
that.
yeah,
Didn't like it.
yeah, no. Well, we discussed putting it in the Boda box that she buys, dumping out the wine that's in the Boda box and putting the fake
Mm-hmm.
wine in the wine box, and it
Mm-hmm.
worked for her 85-year-old mom. And honestly, the reason I came up with this idea is because this is what happened with my father-in-law in his
Mm-hmm.
lockdown unit. They just
Yeah,
started giving him wine, and he thought it was wine, but it really wasn't. It was just
yeah, yeah.
something fake. So,
That's a great idea. Yeah,
mhm.
yeah, yeah.
Yeah,
She
I
didn't
feel
want to.
like
Yeah, go ahead. Go ahead,
I was
Henriette.
just gonna say, I feel like sometimes you have to give permission,
Yeah,
like with
yeah,
parents and
yeah.
with young kids, and
Mm-hmm.
older parents, like just like you can't like be too rigid on this. Like, I don't want to lie. Like,
Right,
what's
right,
in the best interest? What's age appropriate? What's
right,
something they
right,
can actually understand?
right.
Like, are you really lying to somebody who really can't understand? Like, maybe if you could talk to your father in a
Mm-hmm.
way that they could
Mm-hmm.
really understand you, you would tell
Mm-hmm.
them the whole truth. But since they can't understand you,
Mm-hmm.
isn't it better to do what's in their best interest at some point?
Right, right. Yeah, yeah. We had that issue with driving also,
Mhm. Oh,
because my
yes, right.
my client. I mean, it's really tough to give up that part of independence, right? And she was, I don't know this before she went in assisted living. I don't remember the age exactly, but she had macular degeneration and wet AMD, and so she really couldn't see much out of one eye, and she had a number of little wrecks over a period of time, and I knew that from talking with her and her husband, but the kids didn't know that. They were hiding it from the kids. When I say kids, I'm talking about older adults too. Um, and she told a story of pulling out in front of a dump truck that was roaring down the street. And fortunately, the dump truck was able to stop, because she could have easily been killed there. But what did turn the corner is she was on a 4-lane road, and she was behind a school bus. The school bus had run into problems, and it was stopped. And so people were coming up, seeing it, and then pulling around, to get around it and all of that. And she couldn't see that well. So she was careful about trying to pull out and not hit somebody. So she scraped the side of the bus from the back of it to the front of it, and just, really bad. Drove home, didn't stop, got home. Her husband said, "What in the heck happened?" Kind of thing. And at that point, the husband dad talked with the children, and they came up with a thing that, well, the insurance company's not going to allow you to drive anymore. And she accepted that. That wasn't true, but she accepted that. So yeah, you have to be a little bit inventive there. So the common misconception is that elders are mostly a burden to society, and this is not. It isn't true. Doesn't have to be true. I'm involved in church with a bunch of seniors. I'm one of the younger ones, actually. And people are volunteering. People have purpose. People are doing things, whether it's family or whether it's going to the school to mentor a young elementary school kid, or coming to the once a month. We have a homeless project where we go to the park and we distribute food and hot food and canned foods and clothes and sleeping bags and all sorts of things. So it's doing things like that, or being active in the music, the music of the church, the choirs or the handbells or things like that. So there's lots of roles. My wife, who did retire a couple of years ago, she goes on Monday mornings and volunteers. This church it's not that many well-to-do church, and so they have a secretary who manages the budget and all that kind of stuff. But they have volunteers, and she volunteers on Monday mornings for half a day and answers the phone, deals with people who come in who are asking, "Can y'all pay my utility bill?" or our car broke down, blah, 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 blah. All those kind of things. So yeah, people can still contribute. We need purpose. So how do we define successful aging? So this is something that I liked. Qualitative studies of successful aging, and this is across the world. This is not just the United States. There's a lot of research in different parts of the world: Germany, England, Australia, China, lots of research. The ability to adapt to circumstances. So that's one of the things that's really important with successful aging, because there's going to come those medical appointments and those times that I can't climb on my roof anymore. So I've been stopped from, I can't go up the ladder and go on the roof to break off the pine straw or blow off the pine straw. It's just not safe with the medicines I take and one thing and another. So I have to adapt. And so we're finding ways to do things like that. And having the positive attitude towards the future, the resiliency, as being more important to the sense of well-being than the absence of physical disease and disability. So there's a paradox of aging. Even as our physical health declines, self-rated successful aging and other indicators of psychosocial functioning improve. So many seniors actually improve. They stop some of the drudgery that they were doing, whether it's parenting young children or work or whatever it might be, and they're finding opportunities to do things they want to do. whether it's travel as much as they can, or going to clubs or activities, or dinner with friends, or working in the yard, whatever it might be. Anybody want to comment on that? What you're seeing?
Sure. Just I can speak personally that travel with a friend of mine whose partner is also not interested or able to travel.
Mm-hmm.
So we've been taking trips in a group setting, not independently like I had done in my younger years, and it's been wonderful.
Mm-hmm. Mm-hmm. Yeah, that's a great example. Yeah, yeah, yeah. We had a bucket list, and one of the bucket lists was we wanted to go on a Viking cruise, a river cruise in Europe. And we did that 2 years ago, a 12-day cruise. And it was wonderful, wonderful. Went from Prague to Paris and all along all those days. And actually, when we were in France, had to pay extra, but one of the excursions was we went to Monet's home and got to see those pictures of the bridge and the flowers, and walk through the house, and every room, there were beautiful pictures that he hung, so it was really great. Yeah.
It closed for the season. It closed for the season, I think, the week before we got there.
Oh, no, I'm sorry. You have to go back.
Yeah.
It's really worth seeing. It's really neat. A little bitty town, but it's really neat. What about others?
Larry, it's interesting that you mentioned the idea about being on the roof, because for a long time I've cleaned my own gutters.
Right, me too.
And my neighbors across the way came over and said to me, "What are you doing on the roof?"
Mm-hmm.
Because I'm white-headed now.
Yeah, yeah.
And I just said, "I'm cleaning the gutters." And they said, "Get down from there. We're going to do it."
That's super. Yeah,
and
yeah.
I was on the low part of the roof. I mean, there was no challenge right there,
Yeah, yeah. Thank you, Meredith. Thank you. Yeah. Anybody else want to share?
My senior client is just her schedule of activities with her religious group and the grandchildren, and her schedule is so busy that she might as well be working full time with all that she's doing. Yep.
She's got structure. She has things she's enjoying doing, but she can choose now.
Mm-hmm.
Yeah, that's great. Thank you, Emily.
Mm-hmm. I often joke about that. I'm hoping when I'm in a nursing home to be the person, having worked in nursing homes, you want to be I want everybody to be fighting over who gets Mrs. Ryder to change her diapers that day. Like you want to be that nice of a patient in the nursing home that they're literally like, "No, come on, it's my turn for Mrs. Ryder."
Yeah. In the nursing home and assisted living, I've seen it where it's who gets to eat at the table with somebody that they really want to. They want to talk about books or whatever it is, Yeah. So it's kind of like middle school in some ways.
There's also a competition for a partner in nursing homes.
Yes.
Because they're developing romantic relationships, and
right.
Sometimes they know who they're with and sometimes they don't, but there is competition.
Okay.
Speaking of competition, it's interesting that some of my seniors who are living in just the 55 and over communities, which I think should be renamed 75 and over, because I don't think that folks 55 are moving there. But there are so many activities and clubs that I've heard, I think several people kind of refer to it as an adult sleepaway camp. But then there are the in crowds and the out that are not part of it. And so there's that social component that can be stressful.
Yeah, it's very high school.
Yes, I think middle school.
Yeah.
Maybe
Okay.
young high school.
Yeah, I agree then. I'll go with that.
Right,
We're
right,
in
right,
Central
right.
Florida. We're not far from the villages.
Yeah,
Oh, golly.
yeah,
And
yeah.
and they are known for two things. One is alcoholism and STDs.
Geez,
Yes,
yes.
yes, yes, yes. Yeah, yeah. Our friends who live in one of the villages, they live in actually uh, over at Daytona Beach in Margaritaville, and they tried to. She's she used to work with us, and she and her partner invited us over and tried as much as they could to talk us into moving Margaritaville, but we're not. We like our home. We don't want to do that right now, at least. So there's a good research if you want to look at research, the MacArthur Research Network on Successful Aging. If you just put that uh, in your browser, Google search or whatever, you'll come up with a number of things that really helps you uh, to look at these different things of active engaging with life and positive aging. So what are some of the factors? Because there is something called frequent mental distress. My mom had that before she died. Now, I can't tell you the whole story there because it would take too much time, but there were reasons that my mom had that. Um, she it did interfere some with her life activities. She certainly didn't eat well. Um, she did like to go have a piece of pie, but other than that, she wasn't big on eating and did lose a lot of weight in the latter years. Um, and she had trouble with maintaining a household because she did have the wet AMD. That was one thing that did it, but also there wasn't exercise or things like that. She did have some personal relationships that she was able to do, but she the short story is that she had a lot of anxiety and some depression. And one of the things that I talked to the physician uh, the last 9 months of her life when she was in the hospital, she'd go to rehab or nursing, go home, go back to the hospital, back to the rehab or the step down unit, and and just back and forth. And I talked to her physician privately and said, you know, do you think you might consider, an SSRI, antidepressant, maybe some anxiety? And he said, it's not going to hurt. And I think it was helpful, but she wouldn't have done. She wouldn't have liked it had she known that I had done that. The overwhelming majority of older adults do not experience FMD, frequent mental distress. And this is some of what I was saying a while ago. It's less than 10% of the adults age 50 or older, 6.5% of those who are age 65 or older. And I think part of the reason it's less for those that are older is because I do think frequent mental distress can cause earlier deaths. I think that may be part of the research there that happens with older adults. But there are some issues, and we're going to talk about some of those here.
Well, Larry, I
So,
think,
yeah,
just a comment. I think that at 50, many people are still raising
still
kids
working,
or
yeah, and raising
working
kids or
so,
raising grandkids.
right.
Yeah, 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 yeah. So the Handbook of Mental Health and Aging, third edition. Uh, this is some material from that, and it provides a comprehensive and timely account of how things process. And it talks about many different components, many different parts of that. So that's a good research, good book, the Handbook of Mental Health and Aging. Part of what was found out is that, like in China, which has the distinction of the largest number of older adults. So China, of course, has many more adults than most countries do, but they also have many that are older, and there's part of that is the difference in socialism, in the way that socialized help for aging and things happen for sure. But counts for almost 20% of the country's population. So they're steadily aging, and that's part of the reason they've gone to saying, well, you can have more than one child. You know, they were restricting childbirth for many years, and now that's not so much the case. But it showed that less than 1 in 3 older adults have good mental health. So even though they are living longer, they're not necessarily in good health. So why is that? So in this case, what the research showed was that the most common mental health disorders among older adults was the prevalence of depression symptoms among Chinese older adults, 27%, so 1 in 4, which was quite high. It was also found that with depression comes a lot of comorbidity with Alzheimer's disease or some form of dementia and reduced cognitive functioning. And that affects the overall well-being, the quality of life, which in turn increases, of course, health costs that come about there. So over 7,000 older adults were part of the study that this handbook talks about. And this is fairly recent, coming from some of the recent stuff. And what are the key variables? What are the factors that lead to more depression and stuff and worse cognitive functioning? So there's a rating that if you're going to work with older adults, it's good to be aware of. Medical doctors are aware of this, gerontologists, and it's called ADL, or Activities of Daily Living. There are significant predictors of depression in older adults. Depression levels and other factors are significantly higher when the ADL is going down, the cognitive functioning, other health factors, life satisfaction is lower. Multiple factors come into play: cognitive ability, subjective life feelings, social support, and functional status are looked at here. So many of the adults who were suffering that 1 in 4 had issues. Now, as I said, some of the cognitive abilities were tied to the comorbidity of depression and anxiety. But social support wasn't always there. They didn't feel that they were properly being able to be functional because they didn't have support. They didn't feel good about their life overall. They didn't have that enhanced mental health. And there is an exam, the geriatric exam, which evaluates overall medical, social, environmental factors that influence overall well-being. So they look at a functional age. How is a person's capacity to live effectively in their environment? So I'm the age, every time I go in, today I go in to see the eye doctor, the specialist, the retinal specialist, and they say, and every doctor I go to except the dentist, ask, have you fallen in the last year? So part of that is measuring a person's capacity to live effectively in the environment that I'm in. Delineation of strength and challenges, resiliency and risk. Do we have the strength? Are we able to do what we need to do to function where we are and the age we are? Biopsychosocial, a home environment assessment, a genogram, which I love, that, hey, there's a family measurement here, assessment, and establishing a care plan. So that's the geriatric exam. And if you can team with a medical professional, these are things that you can look at and contribute to. And many, I've worked in two, over the years of my practice, I've worked in two medical practices for 10 years each. One of them was a family practice with two physicians and a number of nurse practitioners and PAs. And then one was a pediatric practice not the typical pediatric, it was behavioral. But it really makes a difference when instead of being ignored, we can be included as part of the treatment team. That really does make a good difference in what we're doing. So I'm going to have to speed up here. So multiple factors, good or poor cognitive functioning is directly related. When we look at depressive symptoms, satisfaction with relationships with children reflects family connection and support. They did some studies in Germany, and Germany as a culture has more family support than most other countries do. It's like 80%. My wife and I were surprised by this some years ago because we were talking with our oldest son, who works at Disney, who's 25 years at Disney, and be retiring probably in the next 5 years, and he's still young. And my wife made a comment. Sandy said, "Oh, Tony, this is something you're going to have to help us with, you know, when things come along." And he said, "No, we won't be. You're going to have to depend on Wesley for that." And we said, "What?" And he said, "Well, because Evelyn, his wife, who he met at Disney, is from East Germany, Dresden, East Germany, and she's an only child. And in their pact to get married and live in America instead of Germany, he promised her that when we retire, we'll go back home and you can take care of old Germans instead of old Americans." And so that's the plan. So we do see that many people, when you look at the older adults in Germany, that is a big part of the success of people having less depression and less anxiety, is that culture of being involved with family. And I saw that with Evelyn's mom and dad, with two of the grandparents before they died years ago, when we would see them, and what they did for them was quite a bit. So I'm going to go past some stuff here because I know our time is going by fast. So we'll talk a little bit about anxiety. These are growing significantly. Anxiety is the most frequent mental health disorder among older adults with depression. And frequently it goes undiagnosed. And that's interesting because people don't think in the medical community always to check what is the role of anxiety. And many of the older adults are not going to go in and say, "Hey, I'm not sleeping well, I'm fretting. You know, I do spend time really thinking of what's ahead or what's going on right now," and having many psychosomatic symptoms. One of the things in the family practice I worked in, we had 3 mental health professionals, and the physicians there were smart enough and aware enough that when some of the things happened, they would say, "Well, I want you to talk to Larry or one of the other persons, and let's see what else is going on." And frequently that took care of some of the symptoms of the reason they came in on the surface there. Yeah, Beth?
So my late husband, we thought he was really depressed for a long time. He would have been 74, and I am about to be 68. And so he, went to several different doctors, and they said, go see a therapist. And it turns out that what he had was the same thing Bruce Willis has, which is called frontotemporal degeneration.
Yeah.
So sometimes what looks like depression or whatever is,
Right.
some really significant changes
Right.
in the brain. And
Right.
it could not be diagnosed with an MRI. He had to have the next, click up on a
Yeah.
scan and
Mm-hmm.
to be diagnosed. But I really am aware of that when I see older people. I live in the villages, by the way, and there
Mm-hmm.
is like those numbers on STDs are very, very old, and it's an old wives' tale.
Okay.
But I love it here, and it
Yeah.
keeps us
Yeah.
active. There's so many
Absolutely.
things to do. It keeps your interest,
It
but
does. It
I
does.
just, I just wish that, you know, people knew more about doctors knew more about that. It's just not always depression. It can be a
Right.
physical
Right.
ailment. So that's all
Yeah.
I have to say.
Yeah. Yeah. The teaming, I think, is the real key there of being part of the team, being at the table, mental health professionals,
Yeah.
LMFT, being able to contribute and be part of the assessing, because you're right. I mean, the first thing is for the physician to check for is there a physiological reason for what's going on, you know.
And
So that's,
sometimes
yeah,
it takes some digging to find the physiological reason.
absolutely. Absolutely.
So you have to,
Yeah.
like certain symptoms that he had that you thought were, like peripheral neuropathy. It wasn't peripheral neuropathy. It was part of this other thing. And incontinence was part of the FTD. And so yeah, it's the big picture is a big deal when people are older.
Right. 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 So I'm going to put my slide moving forward here. Um, hmm. There we go. Okay. So I'm going to skip some of this. Um, you'll have some resources here, but I'm going to skip ahead. So here's some here's some really good inventories that can be helpful to you. The Geriatric Anxiety Scale, GAS, the Adult Manifest Anxiety Scale, AMAS, Geriatric Anxiety Inventory, GAI, the Worry Scale, WS, Beck Anxiety Inventory, Penn State Worry. So you see there's a lot of resources out there. And these are things that need to be included in trying to figure out, well, what is going on here? Like Beth said, you can't always tell easily. So these are some of the good inventories. So those things will be in the recording.
Larry, are there any of those that you recommend?
Well, this slide, the most promising that just shows overall is the Geriatric Anxiety Scale. It was developed by Siegel and colleagues, and you can actually get it free if you contact Siegel. It's a Likert type scale. Let me get to that page here. Here it is. So aging and mental health lab.uccs.edu scale. So if you send that, then Dr. Siegel will communicate with you directly and he'll provide you the measurement, the GAS, for free. So you can get a copy of it that way. And these are the kind of things that if you do want to team up with a physician, then this is something that they would pay attention to. If you have something like that you can show them if anxiety is present, if that is an issue. So aging and mental health lab.uccs.edu scale. So we'll talk a little bit about depression, and then I want to be sure we move on to some of the other things there. So as we said, depression can be high, but it's not as high as many. The myth is that we're not all going to get that. But we do know, for example, that, 70% of people with depression, 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 70% of people with de for a while. That's not true today. It's gone down slightly from being the highest suicide population group, but the highest population group for some time was older white men, and we're about to come upon, we're about to have a time change in about 2 weeks, I believe, on that, which I hate. I hate the time change. But a few weeks after the time change, it's the highest time of the year for risk of suicide. So be aware of that. That's why they do the month of May is the suicide, being aware. You'll see lots more publications about being aware of suicide risk in general. This is not just with older seniors, but that is something that we want to be aware of. So what are the symptoms? And so this is from the DSM-5-TR. Depressed mood, loss of interest or pleasure, psychomotor agitation or retardation, weight changes, sleep disturbances, fatigue, feeling of worthlessness or guilt, cognitive impairment, suicidal thoughts. So at least 5 of those symptoms during the same 2-week period need to be present to do a diagnosis, to meet the criteria for a diagnosis of major depression disorder. That's how I knew that the guy yesterday, as we talked, was not really depressed, didn't have any sleep disturbance, didn't have any weight change. He really still had the same interest in doing some activities. He just didn't have his friend group to do them with. So that was part of the problem in relocating away from the area where he had all those friends and social support. So depression is tied to the leading cause of global disability. So if you look at the WHO, which I know is not so popular nowadays among some of the United States, but as global life expectancy increases, it's predicted that more people above the age of 65 will seek support for depression, for diagnosis and treatment of depression. And it is a serious condition at any age, but it is a complex problem for older adults also, if it is there. When left undiagnosed and untreated, it often produces adverse effects such as physical illness, decline in functioning, and so on. And I want to get past this so we can get to some of the things to help with it. So you will have these in the recording you can look at. So there are some of the resources that I sent to Lynn are just a whole bunch of resources to look at. It'll give you links to look at that Annalyn has that she can send out. So the Center for Mental Health Services, Substance Abuse and Mental Health Services Administration there with NIH. 4 things to know about depression in older adults. Depression can be treated at any age. Depression can be treated. It's important to seek help early on. The signs and symptoms of depression vary. For some older adults with depression, sadness may not be the main symptom, just like the client I saw yesterday. He did have anger, but he had that for reasons. It wasn't just general for no reason. Friends and family can help offer support, and living a healthy lifestyle can help reduce feelings of depression. So balanced diet, being physically active, all of those things. I'm going to skip past some of this because we just don't have the time for all of these things tonight. So here's a good YouTube video about older adults. It's a YouTube video there. You see the the link, you'll have that you can go back and look at. And it's a really nice video about mental health in older adults. And NIMH, SAMHSA, those are good resources. They're in that stuff that I gave Cynthia Lynn and Dr. Schooley. So let's see. So let's get forward from some of these studies here. So what they have found in like this Montreal study on aging that took place was that having a sense of safety, a neighborhood that was supportive, people that were supportive, coping strategies that helped develop a protective factor did help with both cognition and mental health issues for the elderly people. And so much of the anxiety, depression may come from like fears, I'm going to fall, or I'm not going to be able to pay bills, or I can't drive, and I don't know what to do to cope with that, how to be resilient and deal with it. I'm going to skip through some of these. There is some difference between men and women. Depressed women are more likely to show appetite disturbance, impaired sleep, and a depressed mood at a higher frequency and intensity than men do. So that's part of the diagnostic issue with elderly people and trying to do that. So when compared to males, depressed females show more frequent depressive episodes in their lives and report higher rates of atypical depression symptoms, excessive fatigue, overeating, oversleeping, anxiety, and some somatic concerns. Some feelings of worthlessness and guilt with men. Men are more likely to be tired, be irritable, lose interest, have difficulty sleeping, turn to alcohol. Men are more likely to turn to drugs and alcohol to deal with some of that. And men may behave more recklessly than women, according to the NIMH research about aging. So I want to leave some time for questions. Let me go through. There's a couple of other things I want to show you here. So what is effective? What does work? So the research shows that medication for depression can be helpful. Psychotherapy combined with medication, combination of that, usually it's the best practice. Many older adults see improvement in their quality of life. Peggy Hansen said, marriage family therapists, with our understanding of intergenerational family systems, our ability to see patterns of behavior and how the interactional dance has evolved over time, respectively joining. So again, therapeutic alliance, you know, that's a huge percentage of success with any therapy that we do. Establishing that collaborative relationship, which many of our systemic models work on. Devise age-appropriate interventions for interrupting the various ways the couple has learned to maintain their particular unhappiness. So all of those things go to helping with the treatment of older adults. So giving people a sense of choice and control over treatment options, a greater role in recovery, facilitating ownership. These are some of the things that have been found in the research on aging that do, and some of y'all mentioned that a while ago when you were talking about the therapy you're doing. So helping them find well, what are my choices? What can I do? How can I change my life or enrich my life or do whatever it may be? So self-empowering to maintain and enhance personal identity as an older adult, whether there is depression or not. And so this study of theory on the components of depression and self-management in older adults, this is part of what came out from the Melbourne and Victoria, Australia Health. And they found that living in their own home, being not being involved in full-time paid employment, diagnosis of moderate depression, support was received, and many of them did respond well to therapy and working with people on self-management. That's a real key that we can do is, well, what can you do? I had a few months ago, I had a late 70s client. I'd seen he and his wife. They both got cancer within 2 weeks of one another, unfortunately, and they both survived. She's healthy, seemingly doing great, but he died a few months ago, and part of that was helping him identify what you could do, what you can do to help yourself, and the choices. And he made a choice, and he decided it was time to quit struggling with the medical community and what was happening when he was terminally ill. And he made choices, and he went home, and within 8 hours he died. And I think that was a big choice, giving him that agency and helping him and his wife be able to talk about what he wanted at that stage of his life in late 70s. So here's a term that comes up frequently. I'll move this down. So there's an approach centered on taking stock. So if you just look at taking stock in working with elderly people, you'll find some research there on a long study that was done about successful aging and psychotherapy. Let's see if I can get it to move. There we go. Okay. So part of the first part of taking stock was an inventory of different elements of life, positive and negative experiences, major achievements and challenges, involve thinking carefully, forming an opinion about the situation. A decision to act is made. And some of the quotes was, "I didn't get out of bed for a week and a half. I fell over a big time collapse, got hold of the general practitioner and said, 'Listen, for God's sake, do something. This is ridiculous.'" So in empowering the adult to be part of the treatment and part of this stage of life, whatever it may be. And so one of the issues was the taking stock, the category accessing support of that active role, becoming informed and engaged. That couple was super at that. They were brilliant. They didn't just go in and not have questions. When doctors were talking about the choice for treating the cancer or whatever it was, at one point it was the sexual relationship was being discussed. And when they got to be a part of it, then we saw positive changes happening. Becoming informed and engaged, harnessing formal support, optimizing informal support, basically taking stock and then being an active role in discussions. Move that up so I can then move forward. One of the things were that sometimes we have to realize that the general practitioner may not be as knowledgeable as we think they are. And so us taking stock and dealing, as I said, with a team is going to be much more effective when the patient's part of that team. The third category was reclaiming self-identity. So this was part of the successful therapy. So what are the resiliency factors here? What are the strategies used where they can empower themselves and have a meaningful existence? A commitment to self-determination and self-management. That was central to their sense of identity as they sought to manage depression, anxiety, challenges, cognitive, functional, all of those things. And they were optimized for taking stock, accessing support, reclaiming self-identity, no matter what was going on at all ages, with physical health, mental health, social health, all of those things was really taking that position. And I think this is a systemic position that plays very well for us that are in the field with marriage family therapy. One of the things it said, don't try and be so much of a bloody perfectionist because you try and do things right all the time. And you probably shouldn't have to worry about doing things right all the time. That was one of the takeaways from one of the clients that was successful there. This was a long-term study of this taking stock study. So accepting change in wellness, illness status typically involve the reconstruction of a sense of self. So today I talked with the retinol specialist because I do want to try to do what I can do. And we talked about taking this supplement. And I said, well, you know, there's side effects with it. And I did take it for a good while, but it's dropped off recently. And he talked to me very, very nicely, very collegiately, joined in on it. He said, well, if that one doesn't work, find a different one. But here's the particular component that needs to be there. Look for one that has this chemical in it, because that's what will help with what's going on. Well, I'll take that. I'll join in because I'm part of the solution. I'm part of what is making that decision, and I'm being consulted. So I'm going to skip through some of these because we're about to run out of time. And I like this third transition. Create new meaning. Participants sought to identify and act strategies to improve their well-being and sense of self. So when my client talked about welcome to my tomb, I said, that's not acceptable. You know, let's talk about this. Let's change the meaning here. Yes, you're not at home. You know you prefer to be at home. But what meaning can you bring? And we talked regularly about what she could do. And it was helpful there for a long, long time until she just got physically where at 98, as Jane said in the earlier book, the wheels fell off of the tricycle. That was one of the terms. She said they don't have that in the medical community for diagnosis, but basically that is what happens sometimes. 98, the wheels fall off the tricycle. And so for whatever reason, everything stops functioning. So self-empowering, optimizing, all of that is just a huge thing. So I'm going to stop here so we can have a discussion. So tell me what you're thinking about. I know it's 7:29. Can we go a little longer, Annalyn? Okay. So takeaways, questions, comments.
One of the things, you know, talking about collaborating with the medical community. So finding that, so my physicians that I've had for 30 something years are retiring.
I know.
I think people within our population are finding, you know, it's a challenge to connect with new medical providers.
Right. Yeah, I've gone through 3 just in family practice personally, and one of them retired. I'd been with him for many, many years, and we were very collaborative. And then I went to the second one, who was a gerontologist, and we don't have that many in Tallahassee. And he was wonderful. He came in, he sat down, he shook my hand, we chatted. One of the decisions I made was we looked at the numbers from the lab work, and I said, can I only take 4 of the medicines for this category a week instead of 7, because there was a side effect of dizziness. And he looked at the numbers and he said, let's try it. We tried it. I went back 3 months later. They did a blood test. It was still fine. So it was still good. You know, I appreciate that kind of teaming up. So we're working with somebody else, but we're still looking for somebody. So the gerontologist got hired by a huge HMO to lead the gerontology program, because it's an HMO. I can't go there. They're not going to accept Medicare and my insurance anymore. So thank you, Robin. Yeah.
So it does sound, as clinicians, that that we need to find gerontologists that will interact with us as providers, to find those friendly gerontologists, psychiatrists that are working with older populations, things like that, that we, as personally, we need to build our team, but professionally, we need to build a team so that we can collaborate with them for the benefit of older clients.
Mm-hmm. Yeah.
Exactly. Yeah, invite them to lunch, invite them to breakfast or something. Don't be afraid to throw that out there. Introduce yourself.
I'll get one to come speak with FFTA.
There you go. Yeah, that'd be great.
So Larry, I had a question about the certification through AMFT.
Yeah.
So I was looking through it, and I was wondering, is it, I feel like as I was looking through it, it looked like it would be interesting, but I was trying to think, does it justify, getting a certification in it?
Not if you're getting a good number of people that in your caseload and you don't feel like you need to up that, then I'd say no. I mean, certifications are certifications, I use EFT. I'm not certified in it, but I went to Sue Johnson's workshops. I've read, things like that.
I have a question. I have had in the last year, at least 2, maybe more, late 80s, early 90s folks show up. And when I say folks, I mean spouses on the death of their spouse. They've come to therapy, and it's their first therapy ever.
Right.
They're grieving the loss of a 70-year marriage.
70-year marriage, yeah.
Or 70, plus 80 plus year old relationship. And they've never talked about feelings or their emotions or anything like that. And honestly, listen, I've worked hospice and done a lot of work. I've not been able to keep them coming in for talk therapy. They started off with, I don't know how talking to someone can help. I don't want to talk about it. And despite my efforts to tell me a little bit about your relationship, how you met, what your favorite parts were, what you're struggling with, what you're missing, it's like it's way too much to have this be the first session or the first time in talk therapy. And sometimes I can convince them to come in for 2 or 3 sessions, but I mean, for the most part, they just don't come back. Now, honestly, they all have had health problems. I don't even know what happened to them, if they're even, maybe they aren't alive. I mean, I really don't know what happened, but if anyone has some more tips, and maybe this certificate would have helped me, but I've worked with the older population, but I have to tell you, I think, like a lot of things, it's really hard to use Uber at 85 if you've never used an app in your whole life. Like there's just some things that I don't know. Talking about the loss of the most beloved person you've ever had, the person that's known you better as an adult than any other human being on this planet, you know.
Well, a couple of things I think of, Annette, is one,
Please.
a virtual appointment may be better.
Oh, a
'Cause
virtual appointment would be better with
yeah,
them than
it
in
could
person?
be. It could be. It could be more accessible for them. And I've seen that with some elderly patients. And then
Honestly, I
also,
don't know if that would have worked with any of these because
yeah, I don't
they
know
had a
either.
hard time.
Yeah, yeah.
I mean, they
I
were,
wonder if
yeah.
in home, if
I've gone
you
to their home.
okay.
Yeah,
Yeah, that would have been a
yeah.
good idea.
Sometimes they
Thank
feel
you.
more comfortable in their own environment
Mhm.
and even getting up to get out.
Mm-hmm.
Yeah, yeah.
Mhm.
That's what I did in the assisted living.
I'm
It was
Yeah,
wondering
I
if
did
it's
one
way too
woman
much
in
trouble.
home. That's a
Yeah.
really good idea, but she even
Mhm.
still decided after 3 visits she didn't want me to come to her
Mhm.
house anymore.
Yeah,
Because
Mhm.
she just didn't get how talking about any of this, it
yeah,
was making her more
yeah.
miserable. So,
And if
but
they're saying, I don't know how talking about it's going to help, that makes me sound to me like it was somebody else's idea to begin with.
oh,
Could
in
be.
all of the cases it was.
Yeah,
Right.
yeah.
So they didn't
Um,
have buy-in. They came to please
Mm,
somebody else. They did it once. They're done.
mhm,
mhm.
Mhm.
So I also think then that the person that suggested that they go be included in the
right,
therapy.
right, right.
So if the daughter
Mhm,
or some other relative
mhm,
is saying, "Hey, mom, dad, you should go," I would have them in the session so that we're not necessarily talking about the grief. We're talking about what that other family member is concerned about.
exactly,
Mhm.
exactly.
And so because they're really kind of the customer, right?
Mhm,
And so to
Yeah.
talk about what are they
Mhm.
worried about, um, and so that actually might join you better with the grieving person because they're like,
mhm,
leave me alone. And so if we
mhm,
deal with that,
mhm,
the other family member's
mhm.
issue, that actually might join you more with the older person.
Yeah, yeah.
Yeah.
One thing that I've also done is
Thank you.
show me pictures. Let me see
Mm.
pictures of the family of your
Mhm.
spouse and the past history. Just pull out the photo books and let's just chat. Uh, Sometimes that works.
There is an
Mhm.
Oh yeah,
online, a
in the
virtual
house visit, we walked throughout the whole house and looked at them. And
Yeah, yeah.
interestingly enough, I think this is important. It was all a friend who was also older, who was also a widow that referred them. And
Mm-hmm,
honestly,
mm-hmm.
I think they were trying to get them to stop talking to them about it so much.
Yeah, yeah, yeah,
Unfortunately, for all of these people, their adult children were not
yeah,
involved.
yeah.
And that would have been helpful. And I did try
Absolutely.
that angle, but I couldn't.
Mm-hmm,
I mean, I feel good after hearing all of your suggestions. I did all
mm-hmm.
these kind of things in
Yeah,
a varying
yeah.
degree, but I think that's
Mm-hmm,
just hard when someone tries talk therapy for the first time at
mm-hmm,
85, 90, and has never
mm-hmm.
done it, and they're grieving.
Well,
Yeah.
having just lost my husband and
Oh, I'm sorry, Beth.
thank you, and I worked with a client in my student internship who lost her husband. I'm still learning. I just feel weird about something and I'll think, I can't make a decision. It's, like 2 years
Mm-hmm,
later, I can't, there's so many things that are different. My resilience has changed.
yeah.
And I have a master's degree.
Mm-hmm,
So
mm-hmm.
to me, I have been educating myself on all the things that you can that the all the ways that your nervous system is affected when you lose that most important person. And so I just am curious whether, like, I'm thinking, would I have liked a therapist to sort of give me a little bit of education about, yeah, you can expect that you can't make a decision, or
Mm-hmm.
like
Sure.
you don't want to be around couples ever again, or that
Right,
kind of thing.
right.
Well,
Yeah.
Beth, I think you are moving in an interesting direction. So, Annette, maybe instead of but providing direct service to these clients. Maybe what we would best be doing is actually offering training to maybe people in churches or people, you know, that are in interaction with these folks, and help them be the ones that hears that story. Like you said, they're tired of hearing the story because they don't know what to do. So if we move to a trainer position for those people, you know, that might be more effective.
Yeah.
Yeah, I was just thinking, as you know, I went to a therapist, and I think it would have been helpful for my therapist to kind of validate some of those things and help me learn what to expect.
Yeah.
So I don't know. It's just a thought.
Yeah.
And
Linda?
Lynn, one of the things that I have found, especially with people who are grieving, is to give them permission to cry.
Yeah.
They just don't want to cry, especially men. They think it's a sign of weakness, or they're not being manly, et cetera, et cetera. And one of the things I always mention is that tears of sorrow are chemically different than tears of joy, from an experiment that was done. And the tears of sorrow, of course, contain depressants. And so, in this magnificent body that God has given all of us, it's self-regulating if you do what you're supposed to do by letting the tears flow through and eliminate the depressants in your system. And that's why so many people say, oh, I feel so much better after a good cry. Literally, they do, because they have dispelled it from their systems through their tear ducts.
So it does sound like one of the things that professionals could take the opportunity for is to create education, to either go and do presentations at churches or in other places like that, or with family members of seniors, or create video, you know, create video about these kinds of issues that might, you know, not only be marketing, but also be a public service.
Right,
so.
right.
Yeah.
Yeah.
Robin, let's see, you said vital support group, lift from loss. Okay. So, so maybe what these folks need who come to therapy really maybe need some sort of support group. Yeah, that makes sense.
Yeah.
And then I also did, there's a training for community people. It was a 4-hour, I think, for helping people with grief. That was really very valuable.
Yeah. So peer support.
Right.
Yeah.
Right.
Great.
There's so many times. There's so many times when, you know, I think older people tend to feel like if we look younger or act younger, that we might not understand. You know, because they've lived through their 70s, 80s, 90s kind of thing, and so, you know. And in particular, just this level of understanding, respect, of course, but it's like, what can you do for me? What do you know that I don't know already? And so much of it is feeling like they already know what's going on, or what might go on, or they've never thought of it. They're just living their life day to day or week to week kind of thing till their next doctor's appointment or the next event or social activity or whatever. So I think that level of understanding is what can you tell me versus what can I tell you or share with you, vice versa.
Yeah, that's good. That's good. Yeah,
Thank
I
you,
like
Mary.
to
This
think
is very
too.
meaningful for me as well in my aging process. It's a definite change.
Yeah, it is. It is. I was thinking from an academic point of view, sometimes with solution focused therapy, you know, we just get clients, and I see this sometimes with older clients, where they get stuck on the problem saturated talk. And if we can use some of the SFT ideas about trying to help them move to small change is good enough, what Ensu used to say, small change is good enough, and get them to move off of problem talk to solution possibilities talk.
Sometimes I use the phrase baby steps.
Yeah.
What might be your next baby step that you would like to have fun with?
Right. Or scaling and going from a 3 to a 3.25, some of those ideas. Yeah. Well, thank you, Annalyn. I've got a family thing to go to myself too.
All right. Well, thank you everyone for coming, and I will be sending you the evaluation. Please get that back to me so that I can give you credit in CE Broker, and I hope you all have a good night.
Thank you so much.
Thanks, everybody. Good to see people.
You too.
Take care.